The moderators for our first section, Dr. Philip Katz and Dr. Sumit Mittal.
Good morning and welcome everybody. I'm Sumit and this is Dr. Phil Katz. The session is on Gerd Pathogenesis. I will introduce Peter Kahrilas if he needs any introduction. He's a professor and chair of medicine at Northwestern, and he'll be talking about the insights into pathophysiology of reflux disease. His talk is going to be 25 minutes.
Thanks, Sumit. Good morning. I'm not the chair of medicine. I don't want to be the chair of medicine, but I was a division chief of gastroenterology for some time. So I have the simple task of looking at the pathophysiology of reflux disease in about 25 minutes. It's not going to be comprehensive, but I will try and highlight certain aspects of it. Not this. I don't really have many financial relationships. I start out with this graphic because, frankly, it makes me laugh. This is the way reflux disease was taught when I was a fellow. This was published in 1971. New England Journal of Medicine, and figure 1, mean LES pressure in millimeters of mercury did not correlate with the presence or absence of hiatus hernia, but there was clear separation of symptomatic and asymptomatic patients just on the basis of LES pressure. Hiatus hernia, irrelevant. Well, circa 2019, there is absolutely nothing right in this paper. So we'll start there. We've come to think of reflux disease according to the Montreal definition, where it's a family of syndromes caused by the reflux of gastric contents causing troublesome symptoms and/or complications. And simply put, you can put it into this equation of triggers being reflux events and the causticity or the acidity of reflux, and then modulators of that, acid clearance and tissue sensitivity. And tissue sensitivity is becoming increasingly important in our understanding of this. But I'm actually only going to focus on the two things on the left here, reflux events and acid clearance. So what's abnormal about reflux events? They can be abnormal in number, composition, or volume. But to get up, it has to get past the lower esophageal sphincter. This is a very elegant reconstruction of the myoarchitecture of the lower esophageal sphincter that Ravi Mittal's group put together recently from an en-bloc computer reconstruction of a human lower esophageal sphincter. So they actually traced the muscle fibrils to show the myoarchitecture of the sphincter, and it doesn't look anything like previous illustrations, really, because you kind of see how if you cut this the wrong way, it's going to look very different. But you have this almost noose-like configuration of the muscle fibers surrounding and squeezing that area. So there's a lot to that. But it's only half the story, because we have come to call this the esophagogastric junction for a reason, because it's got the lower esophageal sphincter, but then it's got the surrounding crural diaphragm as well. Another CT reconstruction, this time from CT imagery, from Dr. Mittal, looking at what happens to the hiatus in normal people compared to people with a hiatus hernia. Now you'll note the red being the right crus over there, that it gets bigger, it gets thinner, and the angle changes. So if this is your augmentation of the sphincter, it's going to be vastly attenuated in the company of a hiatal hernia. Now, the other player is, of course, the transient lower esophageal sphincter relaxation put forth by John Dent in the early 1980s, late 1970s maybe. And this is a neural reflex that we really glommed onto as an important mechanism of reflux. So what is it? Well, this is the anatomy. If you distend that area, you actually activate vagal afferent nerves through these IGLE tension receptors. That goes through the brain, more through the brain, back to the myenteric plexus, where you have this family of excitatory and inhibitory neurons, and they mediate lower sphincter relaxation. So this is a reflex. It inhibits the lower esophageal sphincter. It inhibits the crural diaphragm, and it shortens the esophagus. So you're literally pulling the sphincter into the hiatus, and that facilitates the escape of material, primarily gas, from the stomach. This is a TLASR in high resolution with little endoclips put on the esophagus to show the shortening aspect of it. So the fluoroscopic images depict the esophagus. You can see the high-resolution manometry catheter in there, and the white circles are tracing the movement of the squamo-columnar junction during a transient LAS relaxation. The second clip, which is not outlined, but you can see the pink line on the high-resolution topography there, is the upper clip. So that distal segment of esophagus shortened 6 or 7 centimeters to facilitate venting of the stomach. This is a reflex that was designed to vent the stomach. And it accounts for most reflux events, certainly in individuals without hiatus hernia, and even in people with hiatus hernia, it's a dominant player. But what changes here is the fraction of non-TLASR mediated reflexes when you also have hiatus hernia. No hiatus hernia, it's all TLASR. With hiatus hernia, you get this mixture of mechanisms, strain-induced, swallow-induced, low LES pressure as well. And to complicate things further, this is the same person at 2 different times in a recording migrating from a non-hernia EGJ configuration to a hernia configuration. So it's not a static thing either. And if you monitor reflux in these people, note that the reflux is primarily happening when they're in the hernia configuration as opposed to the non-hernia configuration. And then there's another aspect of TLASRs. Now, when this was first described, people assumed that, oh, these are going to be more numerous in people with reflux disease than not. Well, there have been quite a number of studies here that have analyzed that phenomenon, and most of them found no difference in the rate at which TLASRs occur in normal people compared to people with reflux disease. The studies on the right did find differences, and I'd say that a lot of those actually are people who had hernias. But a much more consistent observation was this one, that if you look at the proportion of TLASRs that are accompanied by acid reflux in controls versus reflux patients, almost uniformly investigators found more acid reflux occurring during TLASRs as opposed to just gas venting. So what happens during a TLASR changes in the reflux population. Why? Well, this is I think, a very illustrative experiment done by John Pandolfino when he was a research fellow, where we actually made an instrument out of a hydrostat, or out of a barostat, and we called it a hydrostat, where we could inflate this little bag within the EG junction to distend it. It's the impetus behind FLIP, actually. But this is the way the device worked. You had a barostat, you inflated air into that, it then exchanged the air, basically, for contrast, which then distended the EG junction, and you could measure the pressure in that bag. Now, we did this not in a resting state, but we did this under fluoroscopy while people swallowed. So you inhibit the lower esophageal sphincter, and you see how widely you can distend it at very low pressures. Basically, pressures all under 10 millimeter mercury. This is an example looking at the 2 projections. And why do we care about this? Well, if you're thinking about reflux as flow, it falls into this equation Isaac Newton's equation, reconfigured a little bit, but the volume of flow falls into the equation that uses pressure differential, diameter to the 4th power, and then you have a constant and length and all that at the end, but diameter to the 4th power. So little differences in diameter are going to make a big difference in flow. And these are the data from the hydrostat experiments. These are the pressures that reflux typically occurs at, 2 to 4 millimeters mercury. But look at the differences in diameters as you look at these 3 reflux populations, or 2 reflux populations in normals. Without hernia, with hernia, those circles are much bigger. And if flow is proportional to diameter to the 4th power, that's going to make a very big difference. And that's what we demonstrate here, where we take this data and simulate flow of either water or air. Now, you'll notice that viscosity was in that equation as well, and there's a 57-fold difference in viscosity between air and water, so the flow of air is going to be 57 times greater. Well, in normal individuals, when it's only opened to about 4 millimeter diameter on average, those are going to be the flow rates for air and water through the sphincter. Very low for water, very high for air. They belch. These are people with reflux disease, but without a hiatal hernia. It gets bigger. Note now you're getting a fairly appreciable flow of water as well as air. And then in the individuals who have a hernia, this model suggests that the flow of water, or gastric fluid, is really very substantial. So you're losing the selectivity of a TLASR for venting gas and allowing it to vent fluid as well. And that goes all the way up the esophagus. When we started doing high-resolution manometry and incorporated the upper sphincter into the recordings, this is what you tend to see during TLASRs. You see this relaxation of the upper esophageal sphincter as the esophagus distends, it vents gas, and in people who have a volume of fluid coming up as well, it will let fluid traverse the upper esophageal sphincter as well. It is the likely mechanism of regurgitation. So we talked about the diameter. Pressure is going to be important as well, although that's only to the 1st power, but nonetheless, its flow is going to be directly related to the pressure differential between the stomach and the esophagus. What's a major modulator of the pressure within the stomach? Obesity, central obesity. These are measures also from high-resolution manometry of just looking at the intragastric pressure in populations of normal, obese, overweight, and underweight individuals, and there is this clear relationship where the intragastric pressure goes up. The intrathoracic pressure or the esophageal pressure has got to stay the same. So this is going to be a bigger driver then of reflux in people with central obesity. And what's happened with central obesity? Well, I think we've all seen these graphics. They get more colorful every year. 1990, 2000, 2017. There's no blue left. And that matters. This is from the Nurses' Health Study, showing that people who change weight, even within the normal weight range, reflux symptoms are directly proportional to BMI. So even if they're not overweight, just going from a BMI of 20 to 25 within a normal range here. It's even more so from 25 to 30, but reflux symptoms vary with body mass index. Well, I think those are the highlights of reflux events. Let's think about acid clearance. This can be prolonged on the basis of hiatal hernia or weak peristalsis. And I introduced this graphic, which is, I think, a classic from Jim Helm, published in 1984, where he instilled radio-labeled acid into the esophagus, had a manometry catheter down, watched the process of clearance both by scintigraphy as well as by monitoring the intraluminal pH. So you see the yellow dots there, that's the volume, and right away there was a peristaltic contraction, it emptied the esophagus. But note that the pH tracing is still under 4, so that only recovers incrementally with the subsequent swallows, and what's happening with the subsequent swallows is you're taking down small volumes of saliva with bicarbonate, you're basically neutralizing it. So there are two aspects to acid clearance. You've got to get the volume out of the esophagus, and then you have to titrate what's left back to normality. That's what defines the acid clearance time. But there's more to that as well. And this is a more recent experiment looking at where the pH transition occurs. So this is after the description of the acid pocket, we started to investigate where exactly this pH transition occurs. So again, there's a high-resolution manometry catheter in place. There's a little clip there on the squamocolumnar junction, and there's a pH electrode that we're pulling back, and you can see which pressure sensor it's adjacent to at each step of the withdrawal. So you can now detect where the pH transition is going to occur in relation to the squamocolumnar junction and the lower esophageal sphincter. So as you do that and you start pulling across, there's -1, you see this phenomenon right distal to the squamocolumnar junction of the acid pocket. What is the acid pocket? The acid pocket is a postprandial phenomenon of acid secretion that layers on top of gastric chyme. So this concept that everything mixes in the stomach, no, it doesn't mix. It sits right on top, and that's that little zone of acidity. And here you have a very nice relationship in this graphic where you see the transition occurring right where you want it at the squamocolumnar junction. But is that always the case? Well, this is a group of patients now where we're looking at normal controls first, and we're relating the position of the high pressure zone there, the EGJ high pressure zone, that's the beige. We've got an endoclip there to show where the squamocolumnar junction is, and then the red dot marks where the pH transitioned to 4. So that's as a result of pulling the electrode up. This is in the fasting, this is in the postprandial position, and summary statement for the normal controls is this pretty much happened right at the squamocolumnar junction. Contrast that with this group of reflux patients. Here's an example of one of them. Note that when they're supine, that point of transition is starting to migrate upward. So it's above the high pressure zone. And when you put them supine in a postprandial position, it's substantially above the squamocolumnar junction. So if you look at the right over there, you see that the transition is occurring 3-4 centimeters up. Well, that's pretty important because that's where you get esophagitis. So you're getting acid exposure in this area without even having a reflux event. It's basically this migration of the acid pocket. These are the summary data from that experiment where you can see that in the Gerd populations, in an upright or even more so in a supine posture, the pH transition occurred substantially above the squamocolumnar junction. You can also demonstrate that by scintigraphy, and this is from the Leuven group over here, where they're marking the acid pocket now by scintigraphy, showing the accumulation of postprandial acid secretion, marking the squamocolumnar junction with a clip, and look at how you're seeing the acid pocket migrate above the squamocolumnar junction. That's with a small hiatal hernia. I thought I had the one with a large one as well, but with a large hiatal hernia, it even goes higher up. I don't know if I can activate this, but this is a little video. Can anybody do this? Because if I push this, I'm just going to get the next. Oh, here it goes. Great. So the other thing that, of course, modulates clearance is peristalsis. And we can't forget about abnormalities of peristalsis, and you're going to see one right here. As you're in the process of emptying, you get retrograde escape. So peristalsis is important, too, in the process of acid clearance. It's the first step. Remember, you've got to empty the esophagus, and there you saw how it can be grossly flawed. So to try to put this together, this is my view of Gerd pathogenesis. You start out with a normal esophagogastric junction. There's synergy between the lower sphincter and the crural diaphragm. You have a tight hiatus, and you have normal LES pressure. You reflux by TLESRs, but it's selective gas venting of the stomach, exclusively by TLESR, and the reflux, whatever fluid reflux occurs, is confined to the very distal esophagus, and clearance is very rapid. You then have instigating factors for reflux disease. These are well known: obesity, diet, age, genetics, pregnancy, sometimes trauma. And that leads to a functionally impaired EG junction. Now, diet-related changes in LES pressure matter. You have increased intra-abdominal pressure, you have increased hiatal dilatation and distensibility, and you have an intermittent sliding hiatal hernia. That leads to pathological upright reflux. This can be non-TLESR reflux events as well. You get more reflux volume because of the increased diameter. It migrates more proximally in the esophagus, where you're more likely to elicit symptoms. You have more liquid during TLESRs, and now you develop symptomatic reflux disease with heartburn, regurgitation, and potentially low-grade esophagitis as well from the increased acid exposure in the very distal esophagus. Well, they then have more exacerbating factors, and now you lead to severe impairment of the EG junction. There's less synergy between the lower sphincter and the crural diaphragm. LES pressure is diminished systematically with the occurrence of hiatal hernia because you no longer have superimposed high pressure zones. You get increased hiatal dilatation. The acid pocket migrates across the squamocolumnar junction, and you get pathological supine reflux, pathological acid clearance, and these are the mediators of high-grade esophagitis. So whereas symptoms are primarily dependent on the occurrence of reflux events, esophagitis is primarily determined by abnormalities of acid clearance. Thank you.